Emergency Medicine, which is our last module in this series by Oriheal Lifesciences. Deeply grateful to Dr. Vishal and Kanika for hosting this series, and I hope you have found it useful. Okay, my name is Dr. Amrita Deb, and we are going to get started for this afternoon. If I'm not audible or visible at any point, Dr. Sharma, please let me know. Okay, so what is collapse? We're talking about acute collapse in feline patients. Collapse is defined as the failure to maintain normal supported posture. Okay, this can be with or without loss in consciousness. And collapse can be acute, it can be intermittent, it can be episodic, or it can be an apparent collapse, where a cat is recumbent, but it is not actually collapsed. Okay. When we talk, the most common presentation that we see is an acute collapse, or an owner will call up and say, oh, my cat is lying on his side and he or she cannot get up. And the most common underlying causes for acute collapse are cardiovascular disease. Okay. So that is HCM, which is hypertrophic cardiomyopathy, the most common type of heart disease in cats. ATE, which we're going to discuss a little bit today, which is arterial thromboembolism, pericardial effusion, and tamponade, okay, which is basically a restrictive cardiomyopathy because of sometimes pericardial effusion. Okay, respiratory disease can also contribute to collapse. So pleural effusion, if it is very severe, it can lead to collapse. The cat is open mouth breathing and not able to walk around. Asthma can degenerate into collapse, and is definitely one of the emergencies that we will be discussing in today's session. Diaphragmatic hernia, when it is acute, can lead to acute collapse. And of course, any other kind of trauma or severe hematological abnormalities of blood loss, severe anemia can definitely lead to a collapse. What is important is when we are heading into CPR, we've got a recumbent cat, apneic cat. Yes, our priority is stabilization, but at some point, one person has got to be free to find out prior medical history while we are stabilizing the cat. When we are doing CPR in cats, one of the most important things is to have a ready crash cart. And this is absolutely essential. It need not be a cart. It can be a box, a tray, a drawer, which is either mobile or portable, or somewhere where the cat can come to. You shouldn't need to run back and forth to get things. What are the contents of this ideal crash cart? Okay, essential contents would be definitely your consent form. In a rush, when the patient is coming in and you can see it's collapsing, nerves are high, stress is high. This is something that we often forget, but it is something that someone must do. Okay, is obtain consent for whatever you're going to do to this patient, your feline patient. You want to have a laryngoscope ready with cuffed and uncuffed ET tubes. 2 to 4 millimeter ID, or internal diameter, is essential and ideal. You don't need to have a lot of sizes, because when it is, unlike in anesthesia, what you want to do is basically get a tube in and establish an airway. Okay, you want to have ties ready for these tubes. Syringes and needles, 20 to 25 gauge, butterfly infusion or scalp veins as they are called. IV cannulas should all be easily available and at hand. Intraosseous catheters or 21 gauge needles. Very, very important component that is often missed is a 5 French urinary catheter. And we are going to talk about when this is used and how this is used. It's very, very essential component. It doesn't need to be 5 French, but it needs to be something that is smaller than your ET tube diameter and can actually go down the ET tube. Okay, but big enough to deliver fluids, drugs, whatever you need it to deliver, oxygen. Drugs, the essential drugs are definitely adrenaline and atropine, but you can also have noradrenaline, dopamine, lidocaine, and atipamezole ready. Atipamezole is the reversal for your alpha-2s, which is your xylazine, dexmedetomidine, and medetomidine, if you have those ready. What I usually do, whether we have anesthesia or any emergency, we always have the dose for a 3 kg cat ready. Okay, this is ready and drawn up in the syringe, ready to deliver at all times. A dose chart is very, very important, and a CPR flow chart. So other than the patient, your team, your CPR team, who should be practicing. So the idea is to practice every 6 months with, a sort of a simulated CPR so that everyone knows what to do when the time actually comes. Of course, your team members can change, but as long as everyone has a basic idea, this is important. And there must be one practice, rather in every practice, there must be one CPR leader who updates protocols and makes sure that things are always kept up to date, refilled, restocked, and ready. Okay, your CPR leader. So dose chart, flow chart, crash cart, and team who knows the protocols. These are your essentials for CPR in cats. There is an initiative called Recover, okay, which is basically reassessment campaign on veterinary resuscitation. And they have a website and they keep introducing protocols and dose charts. And what they have found that there's something that we are also going to talk about. You'll see it in the chart. It is called ROSC, which is return to spontaneous circulation. That means your cat has come in collapsed and you want to return it. The heart has stopped beating. There is no heartbeat. There is no pulse. You want to return it to spontaneous circulation. And rates are ranging between 42% to 72%. Okay, so there can be as high as 72%. Of course, these 72% are usually the ones which are anesthetic collapses. And therefore, these are healthy animals usually who have collapsed, whereas the 40% can be the ICU or hospitalized patient who have underlying disorders. So your success depends on that as well. It always helps to be ready. And the reason that I've put up this dose chart, the Recover dose chart is readily available. And we actually have that one laminated on our crash cart in the clinic, because it gives you the high dose, low dose of epinephrine, and it gives you in volumes the amount for different kg animals. It's a very, very useful chart. The reason I brought this up is because yes, adrenaline we've talked about, and there is a low dose, which is 0.01 milligrams per kg. You can repeat every 3 to 5 minutes if necessary. We don't use a lot of vasopressin, but if you have it ready, you can alternate it with adrenaline. Atropine is an extremely useful drug to have, even for toxicity in your toxicity box. It's a really useful drug to have. And 0.02 to 0.04 IO or IV can be given, and this can also be repeated. And lidocaine, when there is ventricular arrhythmias, it is indicated, but it should be used cautiously in cats, because from our earlier lectures, we know that the safety index of lidocaine in cats is quite low. What I want to draw up over here is, or rather highlight over here, is that suppose you have a collapsed cat, you're not able to find veins, you don't have enough manpower. All these drugs can be delivered intratracheally. We all know that. We know that intratracheal administration is possible, but perhaps a couple of pointers that are mentioned over here is that do not dilute your drugs. You want to increase the volume. What you do is you pass the 5 French catheter through the ET tube down into your airway, and then you deliver the drug after diluting it so you have a sufficient volume. So you can use 5 ml of distilled water, and what they say is distilled water is better than saline for enhanced absorption. So that's one pointer. And the second pointer is you actually need to use 3 to 5 times or 3 to 10 times the IV dosage. So you need to go 3 times the dosage that you use IV when you're using the same drug intratracheal. So these are two things that I wanted to point out to you, which is why I put this table up. Okay, so you have your dose chart there, you've got your crash cart ready. Next, you need the CPR algorithm. It's just a simple flow chart. Okay, if you read through it once, I think all it establishes is, look, what do I do next? When you have a collapsed animal, what do you do next? So what it says is, you have an unresponsive apneic patient, you start CPR immediately. Earlier, they say don't even, earlier it was ABC, which is airway breathing circulation. And so you established an airway first. Now they say if you have a non-responsive apneic patient, immediately start compressions, which is pumping the heart. Okay, so your basic CPR, there is basic life support and advanced life support, and your basic life support is BLS and advanced life support is ALS. So BLS starts with CPR. One cycle is 2 minutes. This includes compressions, 100 to 120 per minute in lateral recumbency, 1/3 to half. We usually use half chest width. In the meantime, you can either put a mask and an ambu bag. If you can get in lateral recumbency, you need to get your endotracheal tube in, and you can administer either with an ambu bag or with your reservoir bag on your machine, anesthetic machine. And you basically want to do 10 per minute or one every 6 seconds, one puff every 6 seconds, and your compression should not stop while you ventilate. And the time of each compression is 1 second. Okay, so 10 ml per kg is your tidal volume. Okay, so if you imagine, it will be 30 ml. It's a slight small puff for a 3 kg cat. It's a 1 second puff, and it's 10 per minute. And there should be a separate person doing this to the person who is doing the continuous cardiac compressions. They say people tire, and therefore one cycle is 2 minutes, after which ideally the person who's compressing should change to give someone else time. It's 100 to 120 compressions a minute. That's 2 compressions a second. Okay, and usually in cats, which is why I've put this photograph here, we do one hand compression. So you're standing behind the animal, you're doing one hand compressions with your thumb and your fingers on either side of the chest, and you're actually compressing the chest to half width. Then you evaluate the patient after one cycle, and you ROSC is if the patient is breathing. Then you go to the post CPA algorithm, which means how do you then stabilize. If you still don't, if you have ventricular fibrillation, you might have to give some lidocaine. Otherwise, if you still have no heartbeat, you repeat the cycle. After 2 cycles of basic life support, you move to advanced life support. Your advanced life support means you must start monitoring. When you start monitoring, remember, you cannot put an SpO2 because you don't have a pulse. So it will not read oxygen because it's a pulse oximeter. Okay. So what you need to have is an EtCO2 and an ECG. This is your basic monitoring equipment when you do advanced life support. You want vascular access. So this is the time when you're going to put in your IV cannula, you're going to get vascular access. If you can't, you're going to put drugs through your ET tube and your drugs. This is when your emergency drugs go in. So your basic life support, which is your compressions, your ventilation, starts before your advanced life support or your drugs start. Okay. At this point, unfortunately, when the reason that you keep everything ready is as much as you're supposed to have everything in control. I think you need 4 people. A 4-people team is ideal. If you can manage with 3, but the leader who is keeping charge and saying, look, change now, keeping time, what to do next, giving instructions, should not actually be doing anything themselves. This is very important, because anyway, you're functioning at half capacity of your brain at that time. Unfortunately, you're also thinking about, oh my God, what has happened to this cat, and what are the owners going to say, and how are you going to explain the situation to them? So it's very, very important that it becomes mechanical, that this actual process of CPA becomes mechanical. And there can be quite good success with it, depending on the underlying cause. So you have a cat who's come in cardiopulmonary arrest. Okay, this cat is collapsed, it's unresponsive, it is not breathing. So first you will start your compressions. Once you've started your compressions, someone will do, they used to say ABC, now which is airway, breathing, circulation. Now it's actually circulation, airway, breathing. So first establish circulations, which is why you're first starting with your cardiac compressions. Okay, when you have a basic return to function, you want to establish your airway with an ET tube and a laryngoscope, and you can use either oxygen. If oxygen is not available, then you can use an ambu bag, rather, the little bags which you can attach and compress. They're very easily available, and I think every practice at least should have one. A 2-minute CPR cycle with a change in operator, 100 to 120 chest compressions per minute in lateral recumbency. Half width of chest, you must stand behind the patient and try not to lean. And you want to start respiratory support with 10 breaths per minute, tidal volume 10 ml per kg, and 1 second inspiratory time. If you're going to give mouth to snout ventilation, you have nothing. You have a collapsed cat, you've done a home visit. What are you going to do? You don't have oxygen with you. You don't have your ambu bag. You will blow into the mouth. It is 1 breath every 30 seconds along with your chest compressions. And you are possibly going to be the only one doing this to try and resuscitate your cat. So what they say is, don't stop chest compressions when you're ventilating. And therefore, ideally, it should be 2 different people who are doing this. And after 2 cycles of basic life support, that is the time when you need to start advanced life support. What is significant is that the major impact of CPR can be very, very rewarding because there's very few things that bring something back to life as CPR does. But they found that basic life support, which is without your drugs, without your IV access, is actually has more of an impact than your advanced life support. So this is worth sort of keeping in mind. And this is about the time when you start also trying to get medical history and trying to get some sort of examination done. Okay. So you also now you have a collapsed cat, but it may not be necessarily in cardiopulmonary arrest. Okay, so this is the next stage. You had your cardiopulmonary arrest. This is the next stage, is where your cat comes in. It is collapsed. It is recumbent. It is mildly responsive. It might be obtunded. It is not very responsive. And you have very poor peripheral pulses, hypothermia, tachycardia or bradycardia. Your cat is possibly in shock. Okay, so let's talk a little bit about shock and fluid resuscitation in cats. Cats in shock tend to have hypothermia, hypotension, and either tachy or bradycardia. So bradycardia is actually supposed to be indicative of a septic shock. So the cat has fallen very ill, it has not been treated, it gets sicker and sicker and goes into septic shock. We actually see this a lot in kittens. So when a kitten comes in collapsed, and this happens quite regularly because they have poor immune system and poor reserves, then they tend to be bradycardic. And when they are bradycardic, this gives you an indication of prognosis as well in terms of warning the owner, because often these are harder to then pull out of shock. It's important to remember that fluids are indicated, but one has to be careful because your initial assessment is very difficult. So you obviously, in these cases, you have done your vitals. This is not in cardiopulmonary arrest. This is a recumbent collapsed cat who's in shock. So you've done your temperature, you've done your heart rate, you've checked your pulses, you've checked your mucous membranes, your capillary refill time, and bilateral femoral pulses always. You've checked for dehydration as well. And cats that are normovolemic before CPA should not be given more than 10 ml per kg of crystalloid boluses. The shock rate in cats can go up to 60 ml per kg, but if they are normovolemic, they are not hypovolemic, then they may not need, and you may land up over perfusing the cat and get crackles in the lungs. So it's very important to monitor for this as well. Warming is very important. If your animal is hypothermic, then external warming by using either external warm hot water, or by warming up your IV line if that is possible while it is going in, covering the cat with a blanket, using external warming devices. All of this can definitely help. Fluids are indicated in all kinds of shock. Okay, so we know that there are different kinds of shock. There is hypovolemic shock, there is distributive shock, there is cardiogenic shock, there is septic shock. It is indicated in all kinds of shock except cardiogenic shock. So when you suspect a CHF, when you already hear crackles in the lung, when you can make out that the mucous membranes are not are white or cyanotic, when you can hear a murmur, or you don't have you have tachycardia and poor pulses, your cat may be in cardiogenic shock, in which case you have to be very, very careful with administering fluids, or rather do a very small volume of fluids. Assess heart rate, pulse rate, CRT, mucous membrane, systolic BP, and any BP which is less than a systolic BP of less than 100 millimeters of Hg is indicative of shock. Temperature mentation after each bolus. So you've given a bolus. So you will start with 10 ml per kg crystalloid boluses. You give one bolus and you assess. Is the temperature better? Is the CRT better? Are the mucous membranes a little more pink? Is the cat finally raising its head or trying to sit up? If there is a good response, then you decide to carry on with another bolus. And once you think the cat is well enough, you must stop. So you actually titrate it to how the cat is doing, and you must evaluate after every 10 ml per kg bolus. There is a minimum database that has been described, and that is basically PCV, total protein, BUN, glucose, calcium. You want your acid-base balance, you want your electrolytes, and if it is possible, you want a lactate. Okay, so this is your minimum database for any cat in shock, because it also helps us to correct underlying metabolic and electrolyte derangements. So moving on, that was your shock and shock and collapse in cats. You may have a cat who comes in and is very, very pale, and in spite of fluids is not being able to get back color into its mucous membranes, and you run the minimum database and you find the PCV is very, very low, and this is an indication for blood transfusion. The reason I've put up a few slides on this is because blood transfusion in cats is very, very different from blood transfusions in dogs. And so I would like to introduce this topic to you and just say a little bit about it. So it is indicated in cases of hemorrhage, anemia, or clotting factor deficiency. It is not indicated in cases of thrombocytopenia or hypoproteinemia in cats. Okay. PCV has to be less than 20% in acute cases and less than 12% in chronic anemia. So this is a very important distinction. If there is a chronic non-regenerative anemia, then number one, it is important to characterize it, because if you are going to replace blood in a non-regenerative anemia cat, you are only buying yourself a little time. And it is important to warn the owner, because the costs can be considerable and the risk to the patient can be considerable, and therefore a prognosis should be given to the owner for sort of long-term recovery. But if there is less than 12% in chronic, because cats do well, they compensate quite well when they have chronic anemia, so that they can do quite well with a PCV that is much lower than a cat who has had an accident and has had acute blood loss. There is no single safe transfusion in cats. And the common blood types in cats are the AB system, which is type A, type B, and type AB. Of these, the type A blood type is the most common blood type in cats. Almost 70 to 80% of most cats are type A. Type B is more common in certain breeds, like the British Shorthair, for example. And AB is quite rare in cats. We're going to talk a little more about this on the next slide as well. Because cats, why did I say that there's no safe transfusion in cats? In dogs, we know that one transfusion is allowed. You can transfuse any dog's blood into any dog. And for the second transfusion, you need to be careful, because then if they are not compatible, this dog serum will develop antibodies to the donor dog's erythrocytes. Okay. And then what will happen is, if you transfuse again, and again they are incompatible, then the recipient's serum antibodies will lyse the RBCs of the donor, and you will get a hemolytic reaction and jaundice. Okay. What happens in cats is that they actually have naturally occurring allo antibodies. So if they are type A, they will have naturally occurring antibodies to type B or type AB. And this is why you cannot, without typing or cross-matching, transfuse blood, because even the first transfusion can have a significant reaction. Okay. So what we do in cats is, this is on the left side, a quick sort of typing kit. Okay. Rapid Vet H. We get the Alvidia kits over here. We used to get it at least till a few years ago, and I'm sure we still get it. And they're very easy to do, and you can immediately type the cat's blood. And in most cases, you're okay to go ahead with just typing the blood. If you have a type A donor and a type A recipient, then you're okay to use this donor for a transfusion. However, recently they have found that in spite of typing the blood, they are getting what is called a positive cross-match in some cases. And in the US, they published a paper where they called it the MIC antigen. So what is a positive cross-match? A positive cross-match is when they're incompatible, when the donors, when the RBC and the serum, the RBC of the donor and the serum of the recipient are incompatible, okay, and therefore can cause a transfusion reaction. So they're saying that, look, even if you give a type A cat donor blood to a type A cat, you can still have a transfusion reaction. And they called it the MIC antigen. But then there were two more papers which came out of Europe and the UK that they said, no, there's no such thing as a MIC antigen. So it's obviously a very low occurrence. Thereafter, they have identified that, yes, it does happen, that it is possible for type transfusions to not be compatible. So that's quite puzzling. And so in general, unless it's an emergency, it is advisable to actually cross-match the blood of the donor and the recipient. So what you do is, there is a procedure where at room temperature, you are at 4 degrees and 37 degrees, you're mixing the washed RBC with serum from the recipient, and vice versa. Okay. And one is called a major reaction and one is called a minor reaction. So you can see in this case, cat Thomas and cat Caillou were tested, and the donor's RBCs, which is your major reaction. So your donor's RBCs are compatible with the recipient's serum. That means your recipient serum should not go ahead and then lyse your donor's RBC. This is a good result. And in this case, your minor reaction, which is actually your donor's serum, is compatible with the recipient's RBCs. Okay. So this is your all green signal to go ahead and cross match this cat. Sometimes, the only times, if you have blood testing kits in-house, you don't have time, it is an emergency transfusion, the owner does not have the resources to pay for cross-matching several cats, because sometimes you have to cross-match several donors, or availability of donors is limited, yes, it is still okay in the face of current evidence to go ahead and transfuse if you can type the blood, or if you can do an in-house patient-side cross-match. But in all other cases, it is advisable to cross-match your donor and recipient in cats. You have a second scenario here where the donor's erythrocytes, so your major reaction is compatible, donor erythrocytes are compatible with the recipient serum, but your minor reaction is incompatible. So your donor serum is incompatible with the recipient's erythrocytes. In this case, again, it is a yellow signal. You can proceed with caution, because What it is saying is that your recipient serum does not have antibodies to your donor erythrocytes. Okay, the donor serum is incompatible with recipient's erythrocytes, but the amount of serum that you actually land up transfusing when you do a blood transfusion, a one-time transfusion, there is so much dilution of this serum that clinically this does not always manifest. You must be ready with your steroids and your adrenaline in case there is a transfusion reaction, but in this case it is highly unlikely and you can go ahead. When you cannot go ahead, of course, is when both are incompatible. So if your major cross match is incompatible, you cannot go ahead. When both are incompatible, you cannot go ahead. When your minor cross match is incompatible, you can still go ahead with your transfusion. So no wonder with all these things now, blood transfusions in cats, blood is called liquid gold. There are many sort of curtailing factors and restraining factors in doing feline blood transfusion. Definitely indications is one of them. Cats seem to do much better in the face of blood loss and anemia than dogs do. Availability, we don't have blood banks and therefore we are reliant on live donors and fresh transfusions. At least in Mumbai we don't. Maybe elsewhere feline blood banks are available. If you do know of one, do let me know. Donor selection is definitely another issue because there are, of course, indications for donors. They have to be more than 4.5 kg weight. They need to be healthy, vaccinated, dewormed. They need to be FIV, FELV negative. Ideally, they should also be tested for mycoplasma and hemobartonella, because if you transfuse this and they start lysing, you will be causing a problem. You want to do a basic CBC biochemistry on these donors before you transfuse, and you want to check for any tick-borne diseases if they are prevalent in your area. So quite a big list, definitely a bigger list than dogs. And of course, temperament I haven't mentioned here, but your donor temperament has to be agreeable also. In cats, we will always sedate. Therefore, the CBC and biochemistry is important. You want to check liver and kidney function of your donor because you will have to sedate them to get adequate volume of blood from the jugular vein for blood transfusion. Typing and cross-match and the MIC antigen, we talked about this. And what I want to show you in these photographs is that, yes, you can use the normal blood bags, which have the CPDA. Unfortunately, we are not going into, this is a whole separate topic. If we go into how to do a transfusion and what is required and how you sedate the donor, I always use a combination of butorphanol, midazolam, and ketamine. So 0.25 of butorphanol and midazolam milligrams per kilo, and 2.5 milligrams per kilo of ketamine. So this sedates the donor cat enough for me to lie it on its back and take blood from the jugular vein with a scalp vein into a syringe. After this, I will either put it into one of these blood bags if I have adequate volume, and I will take about 10 ml per kg maximum and give this cat some fluids through an IV cannula. I will replace the fluids that I have taken. And the other option is if you can get these filters, which are called Hemonate filters. They are available they used to be available from Jorvet on Amazon.com. They're extremely useful things to have, because what you can do is then directly, so what you do is from the blood bag, you draw up CPDA in your syringe, in your 10 ml syringe, and the ratio is usually 1:9. So 1 ml of CPDA with 9 ml of blood. Of course, you coat your entire syringe, you've coated your scalp vein that you're using to draw the blood. And once you've got the blood in the syringe, you can directly transfuse it, just adding this filter and to the IV set of the recipient. So of course, you have to control the rate and do it very slowly. If you don't have the Hemonate filter, then you use the normal giving set with the filter that is inbuilt into it, the normal blood giving set that you get at the pharmacy. Transfusion reactions, your transfusion rate is indicated at 0.5 ml per kg per hour for 15 minutes. You wait to see if there is any acute transfusion reaction. So you have to monitor temperature. You have to monitor for any facial edema, for heart rate and respiratory rate, and mucous membranes for any jaundice. So you can get tachycardia, fever, salivation, and vocalization almost immediately. If you don't, you can proceed with your transfusion at 1 ml per kg per hour for another 15 minutes or for however long your blood transfusion takes. So they need to be monitored, these transfusion reactions, and they need to be managed. If they do happen, then they are quite responsive to glucocorticoids, so either dexamethasone or prednisolone. I would use dexamethasone because it's faster acting in these cases, so it's useful to have it ready. Diuretics for any volume overload. So this is another important thing. When you're doing a blood transfusion, you are replacing a large volume, and cats are especially prone to fluid overload. So it's very important to monitor them for fluid overload. And if it is there, then you can use diuretics, oxygen, and adrenaline, a 1 in 10,000 solution at 20 micrograms per kg. Okay, so that was a little bit about blood transfusions, and we will move on now to aortic thromboembolism. I want to again quickly introduce this topic because this is another very common presentation of an emergency in feline patients. So ATE, or aortic thromboembolism, is an embolism or a breaking away of a clot in an artery causing ischemic neuropathy. Okay, so it basically blocks the blood flow and it causes ischemia and then an ischemic neuropathy. In most cases, this emboli forms in the left heart. Okay, so the formation is in the left heart due to an underlying cardiomyopathy. We know that cardiomyopathies can be occult or hidden in cats. They can have cardiomyopathy without showing any clinical signs. And then it lodges at the aortic trifurcation. Okay, so where it kind of trifurcates into the internal and external iliac arteries. Okay, and that is called a saddle thrombus. And here we have a wonderful photograph of it, of the aorta coming down, and this is your trifurcation, and there's your little thrombus sitting right there, which is then causing the ischemic neuropathy. So what has been implicated? Why do we suddenly get these cats like this with a thromboembolism? Underlying heart disease is the most common cause, but in the absence of that, thyroid disease and neoplasia can also cause a hypercoagulable state and therefore predispose them to thromboembolism. Diagnosis is on the basis of history and clinical signs. There's 5 Ps. Aortic thromboembolism, when it is a classic case, and I will show you some few classic cases, what are the common symptoms, is very easy to diagnose, but it should not be missed. When it is a partial embolism, it can sometimes be a little more questionable. So your 5 Ps are basically your cat will present in acute pain or distress. Okay, there will be pallor. Okay, and this can be pallor of the distal extremities. There can be paresis or paralysis of these distal extremities because these vessels then go on to supply the hind limbs. So one or both limbs can be affected with paresis or paralysis. There can be poikilothermy, which means that your temperature, so the limbs are actually cold to touch, and pulselessness. These are your 5 Ps, pulselessness or absent or weak pulse when you are monitoring for your femoral pulses in that affected hind limb or both the hind limbs. Okay, that's your 5 Ps. You can also confirm your diagnosis by a ultrasound because you can visualize the descending aorta very well, and then sometimes you can clearly see the thrombus, which is present as a cloudy structure within the anechoic vessel. Okay, the classic presentation of an ATE patient is acute pain. So sometimes the owner will call you and say the cat was absolutely fine, and then suddenly it started vocalizing very loudly, and then it couldn't move and it was getting distressed, and now it's crouching in a corner and not coming out. This is usually an older cat, and possibly it is due to underlying cardiomyopathy. The other important association, and this has been also cited in literature, is that cat like this, an older cat, has been sedated for something stressful, maybe a dementia when it's getting older, something like this, and thereafter, for some reason, that anesthesia has caused embolism of the clot which is sitting in the artery, and the cat will then present a week later with ATE. Okay. So this is accompanied by paresis or paralysis of the affected limbs. The paws may appear pale or cyanotic and is often cold to touch. Femoral pulses are weak to absent. Okay. Treatment is with unfractionated heparin subcutaneous, and long-term, this is the short-term treatment, and long-term it is with aspirin and clopidogrel. These aspirin is safe enough in cats, but it has been associated with recurrence. So drug of choice really for long-term management is clopidogrel. You will find these cats will sometimes present with a much higher platelet count than is normal. 70 to 80% of cats with single limb affected survive to discharge. So when it is caught early and treated, they actually do quite well. So for the cats who are presenting with ATE, there are some certain factors that they have found which help us again to diagnose that these cats are usually older. They're 8 to 9 years of old. For some reason, males are more predisposed than females. Maybe something to do with estrogen. I'm not sure. This is my hypothesis. Less than 12% of the cats had a history of heart disease. But what they say is 1 in 5 cats with occult cardiomyopathy will suffer from aortic thromboembolism. So it's very, very important when you're discussing preventive heart scans or pro-BNP with your senior cats that you bring these figures up to let the owners know that, look, it's a one-time test. When they're 8 or 9 years old, hopefully in 90% of the cases, they will, if they are going to develop heart disease, they will already be developing signs that you cannot diagnose it on X-ray or on clinical auscultation or cardiac auscultation in a lot of cases. And therefore, it's important to do those tests. Okay. 40% of cats with ATE, again, therefore, can be normal on auscultation. You will not find cardiac abnormalities, but you must go on to check the heart because you must treat the underlying condition. Otherwise, it will recur. So this is a photograph of the cat. I've actually borrowed it because I don't have a photograph, but this is a very, you can clearly see the cyanotic discoloration of the foot pads as compared to the other. Sometimes if you shave the fur, you can actually just see a patch on the skin gets discolored on the skin of the limb. It's cold to touch. And even if, for example, if they are paretic but not paralytic, you may not have an absence of femoral pulses, but they can be reduced. An important clue that I actually read in one of the papers is that if you can take a blood glucose from the affected limb, then if there is an aortic embolism or an ischemia, then your blood glucose should be lower than what is measured in the rest of the cat's body or any of the other limbs. So that's one tip. Right. So moving on to, I just wanted to introduce you all to aortic thromboembolism. Anyone who is interested in reading, there are very good references, and I'm happy to share some as well. And I have described it, the treatment, etc., in a little more detail in the notes that I will be sharing with you down this week. So let's move on to common toxicities in cats. We have a few more topics to discuss before we move on to our respiratory emergencies. So possibly lilies, the flower lilies of the genus Lilium and Hemerocallis are very, very common and important poisons in cats. They're extremely toxic and result in acute renal failure, and we will be spending some time discussing these in detail. I would like to mention here permethrin. It's one of the most common toxicities, and the source of permethrin or toxicity or pyrethroid toxicity in cats is usually from ingestion of the spot-on formulation for ticks and fleas that are meant for dogs. So either the owner has accidentally used it on the cat, or else the cat can even have licked it off the dog. So it's very important, if there is a dog and a cat in the same house, to warn the owners if one is using, for example, Ephetix, which has got permethrin in it, then to make sure that it is separated from the cats at least till that area dries. Okay, we can discuss a little bit about permethrin toxicity. So basically what we see with the permethrin toxicity is that a 1 ml of a 45% permethrin is, when it is applied to a cat's skin, is enough to cause signs of toxicity. Initially, the signs of toxicity can be hypersalivation, vomiting, uh, cat becoming very inactive or lethargic, and this can then progress to hyperreactivity or hyperresponsiveness with ear twitching, limb twitching, or continuous twitching of the cutaneous trunci muscles. In some cases, this can progress to muscle fasciculations and seizures and can be quite difficult to manage. So they say that in these cases, diazepam is not indicated, rather methocarbamol. So the trade name is Robaxin is the actual trade name. And in India, it's Robinax. And this is safe to use. And the dosage range is from 55 to 220 milligrams per kilo IV. But they say you should not exceed more than 330 milligrams per kilo in a day, because you can actually cause, this is a muscle relaxant. They use it also when they're, for humans, when they're passing an ET tube, and it can cause over relaxation of your diaphragm and respiratory arrest. So that is something to be careful about, but it is largely safe. The most common clinical signs that were associated with permethrin toxicity were fasciculations, twitches, hyperesthesia, seizures, pyrexia, tyelism, ataxia, mydriasis, and temporary blindness. Okay, the important sort of differentials for permethrin toxicity is carbamate toxicity. That is also a group of pesticides that is toxic in cats. And I think an important thing is to use atropine in these cases. For the mydriasis, permethrin or pyrethroids will respond, whereas carbamates will not respond. In all these cases, if a spot on has been applied, decontamination of the fur by washing is one of the most important steps, but it is important to make sure that the cat is not aspirating any fluid when it is washed and it is not getting hypothermic. Okay. Ethylene glycol, I'm sorry, I apologize for the typographical error on that word, but it is not so common. It's the antifreeze poisoning, but it is a known pesticide in cats. NSAIDs, AKI or acute kidney injury in cats post anesthesia. They say there is no safe dose of NSAIDs in cats. This doesn't mean that we should ignore pain and not use them. It just means that we must use them in caution within, normal cats with no evidence of azotemia, and use it along with enough fluids and make sure that the cat is not dehydrated. Paracetamol, we had mentioned in our don'ts, and we're going to talk a little bit about this. 50 milligrams per kilo is the toxic dose in cats because they lack glucuronil transferase, which is responsible for metabolizing the paracetamol in the body. But doses as low as 10 milligrams per kilo of paracetamol have been associated with vomiting, depression, anorexia, and hypersalivation in cats. Perhaps the biggest problem with paracetamol is it causes methemoglobinemia. Okay, tongue twister there. And what we see are muddy brown mucous membranes. It also causes Heinz body anemia. The treatment is by N-acetylcysteine. This is your drug of choice for paracetamol poisoning, and it can be given orally or IV. So the ideal dose is 140 milligrams per kilo IV, followed by 70 milligrams per kilo IV every 4 hours for 5 to 7 times till your cat stabilizes. Otherwise, there is a chance that the cat will also go into acute hepatotoxicity. So what you're trying to do is you are trying to protect the liver and from getting damaged. Along with this, by the way, because you have methemoglobinemia, it is important to have your fluids going because you want to mobilize the current RBCs and, of course, give oxygen support. So these are the different aspects of paracetamol toxicity. So N-acetylcysteine, I don't know. So there's a tablet called Nefrosave, which has N-acetylcysteine along with taurine, and this is quite safe. But the only problem, and of course there's Mucomist, which we use a lot for nebulizing, but it can be used IV as well. It can sometimes cause nausea, so it's important to give an antiemetic along with it when you're using it. And when we use the capsule, it can be very, very bitter, so that oral capsule can be quite challenging in cats. Onions and garlic, like in dogs, and rodenticide, like in dogs, similarly cause the same mechanism of toxicity and are treated in the same way as they are in dogs. Okay, so when they studied the common intoxications of cat with at the UK's Veterinary Poisons Information System, excuse me, information service, they found that actually the most common toxicity was permethrin, you can see over here, and lily. Okay, these accounted for the maximum number of toxicities in cats, leaving everything else quite far behind. So everything that they didn't know was clubbed together as unknown agent. But other than that, actually, these are by far the most common toxins in cats. Therefore, we'll spend a little time talking about lilies, because this is something they say the first, and really it is true. It's true with rodenticides, it's true with lilies. The first and most important thing with preventing toxicity is owner awareness. And to have a little leaflet out just to saying what the common toxins are, which goes into your file when your patient registers at your practice, can be really helpful to mitigate um, the effects of toxicity when, if and when it does happen to occur. So lily is toxic. This lily plant of the Lilium and Hemerocallis genus. So actually all types of lilies is what they found are toxic. And you know, it's these big white flowers. We get them in India and they have the brown, whatever these stamens, I don't know, not really sure. And they have brown pollen and it stains your clothes. And they found that every part of this plant is extremely toxic for cats. So even if a little, so it's the plant, the leaves, the stems, every single part of this plant. So this flower should not come into a household which has a cat in it. Because even if the cat brushes against it and some of the pollen comes on the cat's fur and the cat licks it, you can get an acute kidney injury just from that. Okay. So what do we see? The common signs that we see if a cat has ingested, sometimes there are no signs at all, and this is important to remember. And in some cases, we will see vomiting, we will see inappetence, dehydration, and if the owner is observant, he will notice that the cat is urinating less, it's not eating, it's not drinking, it's urinating less, and sometimes not urinating at all. Okay, it's very, very important if a cat presents like this recumbent, that you don't try to give it anything to make it vomit, because it can then aspirate. So this is very, very important. Decontamination of most toxins are similar. First is you want to decontaminate the coat. So you wash the coat if there is any pollen or anything on the coat. You can induce vomiting in cases of toxicity if the cat is okay and has just presented after, within 2 to 3 hours. Interestingly, apomorphine is not indicated in cats because the mechanism that it acts with it's not as effective as an emetic in cat. And number two, it can cause behavioral side effects. So if you already have a cat who has ingested a toxin, then you may want to reconsider using apomorphine. What is actually quite safe to use, or rather easier to use, may be a new generation alpha 2, which is like a dexmedetomidine, but you want to use a really low dose. Sometimes it helps to feed the cat a little bit and then make it vomit, because it's easier for the cat to vomit everything along with the food. And you must always, if you're going to use an alpha 2 for emesis, for inducing emesis, it's very, very important to have the reversal with you. Otherwise, do not do it, because if they get sedated and then they vomit, then you will have a bigger problem on your hands. Activated charcoal is good because it will stop, it's an adsorbent and it will stop absorption of the toxin. So you want to give 1 to 4 grams per kilo orally. You want to immediately start fluids. We know that lilies cause acute kidney injury, and therefore you want to immediately start fluids. 4.4 ml per kg per hour for 48 hours. Monitor urine output. If it is not if it is anuric or oligouric, then you might want to consider a diuretic. As long as you have corrected any fluid deficits, then you can use furosemide. That is not a problem to induce diuresis. Antiemetics we discussed. Monitor renal parameters for 48 hours. And if the cat is inappetent, then institute nutritional support. That is a good plan. So this is Mojo. And Mojo's pet parents are very aware, and they brought the cat in saying, look, Unfortunately, Mojo we didn't realize, and he may have sniffed at the lilies we had in our house. We immediately threw them away, but we are not sure if he has ingested a little bit. And it happened on the day that he was presented, and he seemed very clinically well. He had not vomited or anything. So we just ran some bloods, and you can see that the CBC is completely normal. Everything is within the normal range. Platelets are slightly low, but that could just be the blood draw. You get a pseudo thrombocytopenia in cats um, because of a slow blood draw. But what we did find is he's a very young cat. He's about a 1.5-year-old cat. And we found his creatinine was 2.3. You can see it's the only one that is at the upper end of the range. The IDEX ranges are till 2.4, but actually anything above 1.8 is of concern in cats, okay, according to the IRIS guidelines. Everything else was fairly normal. We checked electrolytes as well. And then we started flushing, and 2 days later, he continued to do clinically very, very well. And we got the owners to wash the coat when they went home and dry him. And we continued fluids, and his creatinine came down to 2.1. We weren't doing a very heavy amount of fluids, but just enough to sort of, keep him hydrated. And he continued to show no signs. Thereafter, because his creatinine was still sort of, above what we liked, we ran an SDMA and it was perfectly normal. We also did a urine routine to check his urine concentrating ability. He was urinating good amounts, and we also performed an ultrasound, and the kidneys were normal in size and looked normal. So this was Mojo, who did quite well. But this is something to remember, that, if you have a cat who's come in and there is any history of ingestion of flowers, then lily and renal values should be checked. It's important for every practice, in addition to a crash cart, like we discussed, to have something called a tox box, which is a toxicity box. And you just have certain things ready so that whoever needs to use it, along with, again, a dosage chart for cats and for dogs, if you're seeing dogs as well. And important things to have in this are, so that you're not running to the chemist when you need it. You have a paracetamol toxicity, you're not running to look for mucomist or N-acetylcysteine. So you'd like to have activated charcoal. You want to have methocarbamol tablets or Robaxin, which is for your pyrethrin toxicity, where you will see a meiosis and you will see the CNS signs and history of pesticide exposure. You will want to have vitamin K1 injections for your rodenticide toxicity. We don't get K1 so easily. It is available, but it can cause hypersensitivity reactions. K3 or menadione is what we usually stock. Interlipid for ivermectin toxicities, if that is available, it's a good thing to have in your tox box. And of course, atropine for all your toxicities, hypersalivation cases, and any emergencies, any bradycardia. It's a good idea to have. Moving on to, again, an interesting sort of presentation in a feline emergency. And I would like to know how many of you have seen cases of high rise. In Mumbai, we have apartments and we really see it a lot. One of the things that I mentioned is the nets, the bird nets, or the netting of balconies and windows when you own cats. And that is because of the incidence of high rise syndrome. Okay. So what is this high rise syndrome? Okay. High rise syndrome was a term that was actually coined in the 1980s. I think 1987, the Animal Medical Center in New York, which is one of the biggest emergencies, they did a study and they looked at trauma that is caused in cats from falling from a height. And they made some very interesting observations. So what cats have, and what this image shows you, is they have a very strong righting reflex. So when they are falling from a height, as soon as I think they stop, there is some physics involved in this, and I'm going to try and explain to you, but I also urge you to go ahead and read about it. It's quite fascinating. You just need to Google high rise syndrome and you will get it. Is they reach something called terminal velocity, which happens at somewhere around 5 floors for 5 stories. Okay. After which they do not sense the acceleration and they're able to then move their body and get onto their limbs and keep their limbs loose so that they land on their limbs and they're able to absorb some of that energy. And so what they found was pretty fascinating. They found that because of this righting reflex that they have, if they fall from the 0 to the 3rd floor, or anything higher than the 9th floor, they actually sustained much fewer and less serious injuries than if they fell from somewhere in between, which is like the 5th to the 9th floor, because this fall didn't give them enough time to right themselves. And this is what is called high-rise syndrome in cats. And then when they looked, there is a certain set of normal sort of traumatic patterns that they saw with this high-rise syndrome. And they studied 132 cats in the AMC, or Animal Medical Center in New York. This is a paper in 1987. And they found that 2.7 years was the mean age. So, of course, if you can imagine, these cats might be going out, looking at birds. They might be intact and hearing a cat on heat outside, and something happens. So a lot of cat owners will tell you, oh, my cat regularly goes out and walks on the ledge. I just want to tell you that until they fall, they don't fall. Okay. And I hope this makes sense, because, and this is what I tell the owners, that look, until that one time that it happens, they go out many, many times and they don't fall. But it doesn't mean that it cannot happen. No cat is too smart or too clever or too scared to jump. And one must not assume this, because it's always the same story. Oh my God, he's had the terrace for so long, and then just one fine night, he saw a pigeon or something that he saw and or got scared, and he's fallen, or she. 90% had thoracic trauma, 57% had facial trauma, 39% had limb fractures, and 17% hard palate and dental fractures. And this is the key to this slide is, if you have a cat who's come in with high rise, yes, of course, you want to do those chest radiographs to check that there is no broken ribs or hemothorax. You want to check that the bladder is intact and the jaw is not broken and the tongue's not hanging out. But you also want to open the mouth and look at the hard palate. Okay. The good news is 90% of these cats recovered with treatment. And what are they telling you to do? So they're saying that when you have a high rise case, always stabilize these cases first before you do anything else. Triage and stabilization with oxygen and analgesia. Auscultation and physical exam, including that oral exam. Survey chest and abdomen radiographs, which include vertebrae, thorax, and urinary bladder. So it has to be chest radiographs as well as urinary bladder. In a lot of these cases, there is a pelvic fracture. The cats are very painful. We usually do a lateral view. We just make the cat, if it's nice enough, to lie on its side, or if it's not, then we get it to lie on its stomach as a DV view. But we try and get chest and caudal abdomen to include urinary bladder, just so we can see it and we can see the spine. Later on, any other limb x-rays, etc., pelvis x-rays can be done once the cat is stabilized under anesthesia. You want to do a CBC and biochemistry to see if there is any internal blood loss that you're not picking up on your imaging. You want to monitor for 24 hours for urination and defecation. This is the most important thing for the owner once you've sent it home on analgesia and cage rest. And wait for a few days to stabilize limb fractures or palatoschisis. This broken palate, it can be much smaller than this. This is quite big and it needs to be sutured. In some cases, though, I've had maybe 1 in 5 cases, the opening is very tiny and it seems to heal on its own. But in most cases, it does need to be sutured. And skull x-rays are very important to look for any underlying bone fractures as well before you suture the hard palate. So that's your approach to high-rise cases.